Welcome, everyone. We have a wonderful third webinar going on today. People with intellectual and developmental disability experiencing abuse, tips, tools, and strategies for providers. Couple of housekeeping. I just want to kind of have presenters introduce themselves as they come in to present. Couple of housekeeping announcements. If you're looking for closed captioning, it is going to be found. The icon is on the bottom left-hand corner, and you can turn your closed captioning on. We are recording the video, the webinar. We will make it available within a week of today's date. PowerPoints, any resources that our presenters talk about will be also made available. I will also put the resources and the links in the chat as we are mentioning them, so that way you can capture them. But if you don't worry, we'll put everything on our YouTube channel and email you once everything is up, so you'll be able to have everything available to you. So today's webinar is in partnership with the National Center on Criminal Justice and Disability, and it is part of a Healthy Brain webinar series. And it is presented by the HealthMatters program. We're located at the University of Illinois at Chicago, and with an additional partnership with the National Task Group on Intellectual Disabilities and Dementia Practices. We are funded by the Centers for Disease Control and Prevention through the Healthy Brain Initiative. The contents are sole responsibility of the webinar presenters and do not represent the official views of the CDC. We have three presenters today. I will let each presenter introduce themselves to save on time, so we can have additional about 10 to 15 minutes of question and answer at the end of this webinar. So the first presenter is Leanne. Should I do next slide? So there you go.
Yes,
and take
thank
it away,
you.
Leanne. Thank you.
And I just realized I still have my Davis name on there, but I recently changed my name. So my name is Leanne McKingsley. I'm the Senior Director of Disability and Justice Initiatives at the ARC of the United States. And if you've been following our series, you've heard me introduce myself before, but I have been at the ARC for 27 years, focused on the intersection of people with intellectual and developmental disabilities who come in contact with the criminal justice system. And through that work, we've been doing quite a bit around supporting crime victims with disabilities. And that's why we've been working with Yasmina and Beth with their work, really looking at some of those key issues. And I will pass it over to Patty.
I'm Patty Quartieri. I'm from Disabled Person Protection Commission Assessor Assault Unit in Massachusetts. Hello everyone. My name is Keisha Weather, and I am a co-chair to the Peer Support Network. I am also an advocate advisor. I am the treasurer, policy chair of the California State Rehabilitation Council, and my regular source of employment is the UCLA Target Center. It's a pleasure to be here. Next slide.
So I just wanted to give an overview of what we'll be talking about in today's webinar. We have had some pretty interesting webinars to date, hearing from healthcare providers, people with disabilities. And so we're furthering that work by focusing on this issue around bias and looking at how we can address that in healthcare. And so what we're going to do is look at some recent survey data and help you to learn how these pervasive attitudinal barriers are still there in healthcare today. And we have some pretty interesting information from a recent New York Times article that highlighted a survey around this topic. So we wanted to share some of that information with you. We would like you to learn how providers can practice effective ways to interact and communicate with people with disabilities. And thank you to Patty and Keisha, who will be giving their own lived experience around this and what has worked for them. And then also understanding the role of peer support and coalition building. These are really two promising practices that can reduce bias. And we'll talk about how that can look. And then just as a little teaser for our next webinar, we'll be going more into detail about how that can really help get to some of those underlying foundational issues that keep bias alive in our culture, in healthcare, in policing, in so many areas in the lives of people with disabilities. So that is what we will be focused on today. Next slide, please. So of course we want to remember that supported decision-making is key to really addressing bias, to addressing stereotypes of people with disabilities. We had looked at one article showing that some small studies reported positive outcomes, with many saying that they were more confident, happier, and better able to do what they want when they have supported decision-making in place. We know that this sort of movement kind of gained momentum with the 2006 approval of the UN Convention on the Rights of Persons with Disabilities. However, of course, this wasn't actually signed by the United States, but we do know that there is momentum in this area, but we want to see how it can be practiced in healthcare specifically. There still needs to be quite more done in this area for that to happen. We've been doing work actually in the international community around justice issues, and we see this type of advocacy really growing. So that's something that we wanted to address and realize that when you're doing this work within your own area, know that you're not alone, even though sometimes you may feel that. There are others really wanting to work to bring this into states, communities throughout the country. And then lastly, making your own decisions is at the heart of what it means to be a person. And we've talked quite a bit about that on this panel, preparing for today's webinar with you. This includes whether the person is a patient or a survivor. So we do have a source document that can be dropped into the chat now, and we can provide you later. This was from the New York Times, an opinion piece around guardianship and Britney Spears. I'm sure many of you have followed that that story as Britney was fighting for her own independence. Actually, that did quite a bit for us to be able to raise the issue that this is an issue for people with disabilities and that we need to be talking about the rights of people to make their own decisions. This was a pretty good piece to just kind of highlight that, and a way to talk to people, maybe not in the disability community, those in healthcare who may not understand this issue yet, to bring this out to them and help them understand just why this topic is so important. Next slide. And so I had mentioned before that I am with the National Center on Criminal Justice and Disability at the ARC of the United States. We are celebrating 10 years at the end of this year, and a key issue that we talk about is supported decision-making. One of the projects that we have is the Talk About Sexual Violence project that is bringing supported decision-making into the discussions of helping people with disabilities decide when and if to report sexual assault. So we're looking at the different nuances around this topic and really helping kind of pinpoint where are the specific kinds of decisions where people need, when they're making those decisions, they need support to do that. So that's part of what we do at the National Center, really advocating to create reform in criminal justice systems and where this issue touches healthcare as well. Next slide. Just a reminder, if you ever need support around criminal justice issues, you're trying to support a victim someone who's been a victim of a crime, sexual assault, or any type of abuse, we are there to provide any support we can, to put you in contact with the right individuals, make sure that anyone who's been a victim of a crime that has an intellectual or developmental disability can get the support they need. So please feel free to reach out to us about that at any time. Okay, next slide. And now we're going, oh, go ahead. Go
Sorry
ahead.
about that, Leanne. I'm going to give you a keyword outline for the video that is called Keisha Goes to Her Doctor. Keisha and her caretaker go to the doctor because she has an infection. The caretaker tells the doctor why they are there. Keisha is quiet and not feeling well. The doctor invites the caretaker to the waiting room. Keisha begins to feel more relaxed. Keisha tells the doctor she hurts. The doctor notices a bruise on her arm and examines it. Joan, a nurse, Keisha knows, is invited in the room and is pleasant with her. The doctor mentions sometimes people with intellectual developmental disabilities have unwanted sex. Keisha says it happened to her friend. The doctor shows Keisha a picture chart with body parts and asks Keisha where it hurts because it's very hard to talk to about it because Keisha is traumatized. Keisha explains that she has been forced to have sex and she hates it. The doctor and Keisha have a conversation. Joan, the nurse, gives Keisha a card with a resource number to call for support. The doctor and nurse had gentle tones to their voices and make eye contact with Keisha, which is very important. They were genuinely concerned about her bruised arm and infection. Even though Keisha was traumatized, it felt comfortable talking with the doctor and nurse about what happened to her. Both the doctor and nurse used everyday language so Keisha could understand what was going on.
Thank you, Keisha. Thanks for providing that overview of this case scenario. And this is the scenario that we've been using throughout the series to highlight different key areas where trauma-informed care is so critical, where we need to watch out for any bias and address that and make sure that people with disabilities can get access to the health care that they need. And so, Keisha, you've been such an important played such an important role in all of this work and being in the videos yourself. I wanted to ask you a question based on this case scenario. And as you're answering that, I'd actually like to throw this question out to everyone out there in webinar land with us today, and also ask you the same question. And if you want to start responding in the chat so we can see some of your answers. The question that we had based on this case scenario that I'll turn over to you first, Keisha, is what can you do if the resources that the doctor provides or the nurse provides, if those aren't accessible? What's the next step?
The next step is if the resource is not accessible, then I go back to my case manager at my regional center or other case management agency to find other resources. I don't give up, and that's very important because you may, even though you talk with your case manager, it's very important that you don't give up until you find the resources you need. Next slide, please.
And as we're going to that next slide, let's see if we had any responses in the chat as well. I'm trying to look at that too. It looks like we did talk to the case manager for support to find other resources. Yes, thank you. Ask for help from the supported decision-making team. Another great idea. So thank you for those. I think one of the things that we've talked about as we've all, Patty, Keisha, myself, we've been doing this work for a while, is when things don't go to plan, what are we going to do? And to help individuals with disabilities understand that you can keep going and you can keep trying, but you do often need support to do that. So Keisha, thank you for providing that example and helping others understand that they can move forward and keep trying and not giving up. It's tiring and it can be exhausting, but you are a great example of what can happen when you can continue to do that. And thank you for sharing just your personal experience on that. Okay, so let's move on to the next slide now that we have set sort of the foundation of our webinar today with that case scenario. Thank you. So when opening the webinar today, I mentioned a survey that we wanted to raise some key points from this, this New York Times article and survey. So the name of the article is Doctors Admit They Don't Want Patients with Disabilities, a pretty strong title. And what this article is looking at is a professor of medicine at Harvard. Her name is Lisa Lezioni, and she wanted to understand why people with disabilities kept reporting that they were receiving substandard care. She was saying, I thought I needed to start talking to doctors. So she decided to do some focus groups and look more deeply into this issue. And ironically, you know, she had said in the article that when she was doing these focus groups, since they were virtual, the doctors she was talking to didn't know that she herself was in a wheelchair. So some of the themes that we really wanted to share and that you will hear come up again as you hear from Patty and Keisha today is around this idea of wanting the doctor to be on your side, but then in reality, that's not always the case. So one of the things mentioned was this first bullet here, that patients using wheelchairs were told to either go to a supermarket, a grain elevator, a cattle processing plant, or a zoo to be weighed. So, you know, when you go to the doctor and you get weighed, you have to provide your weight. This was happening to people using wheelchairs. Another key point from this was that disabled patients take too much time, is what some of the doctors said. It's disrupting our clinic flow. Another point was all went well until a person mentioned he had a wheelchair, and then all of a sudden his appointment was canceled. So we have heard this from the disability community as well, that for fear of, you know, not having what people think they need, or not wanting to bring in people with disabilities for whatever reasons, that all of a sudden their appointments can get canceled. They also talked to people with disabilities themselves in this article and in the survey. One person with disabilities said, some will find every excuse to not see you. And then the last one, I really don't know what to do with you. Maybe you should go elsewhere, was something a healthcare provider told a person with a disability. So this just really kind of sets the stage of why it's so important that we are doing this kind of education and helping healthcare professionals understand just how harmful this can be, this type of attitude where they may not even realize that people with disabilities are understanding that they're being discriminated against. They may or may not. But the issue is we have to do more education around it. And so we want to talk today about how we can address this and make sure that we are organized around this more efficiently. How do we provide individual responses to this? but then how do we collectively provide responses that can actually change things over the long term? Okay, let's move to the next slide. So what I'd like to do now is open it up to our panelists today. We want to hear from survivor self-advocates around this topic specifically. So Keisha, I'm going to start with you on question 1. Can you tell us what have you experienced and what have others shared with you regarding bias or being stereotyped?
Yes, definitely. One of the things that I have experienced and others have experienced as well is that my support, like when I go into an appointment, my support person is the focus for the healthcare provider, and not the individual with the disability. There's no first contact between the healthcare provider and the person with disability. I mean, when that happens to me, I absolutely feel totally invisible, like if I'm not even in the room, because they're having a conversation about me, but not with me. And that goes back to the disability model that says nothing about us without us. And so it's essential for the healthcare provider to talk to the person with disability first. And we also need to ensure that the healthcare provider is the same gender when talking about sexual violence. If the person who assaulted you is the same gender as the healthcare provider, this can definitely be a trigger.
Great point, Keisha. Thank you so much for that. And that feeling of being invisible really can make people not want to go back to see that doctor or to see that nurse. So you raised such an important point there. And I really thank you just for being that honest about your experience and helping us really get a window into what people are experiencing. So let's hand it over to Patty. Patty, what do you think about this question?
I am not always treated well, so I am not giving good directions about what I am supposed to. So I get confused and frustration. It really helps when I am talking to and show what I have to do. Like when I need to take my blood pressure.
Mm-hmm. Yeah, good. Another good example. So providing clear directions is very important. And I think one of the things that can get in the way of that is even having enough time in the appointment for that to happen. And I know that we're going to talk a little bit about that here in a second as well. So let's move on to the next slide. So let's talk about bias and get a little bit more examples from you. So we're talking about bias in healthcare and what that looks like. One example that we had talked about is assuming competence, and that sometimes healthcare providers don't assume that you can answer things. They may, like you were saying, Keisha, they may automatically go talk to the support person, assuming that you wouldn't be able to answer for yourself or give you the opportunity to get support to answer a question for yourself. So let's talk a little bit more about this specifically. Keisha, can you give some more examples about bias?
Yes, of course, Leanne. Many times when I go to the doctors naturally assume I don't have the competency to make my own decisions. Like they thought I couldn't make an informed decision about a minor medical procedure. And I mean, that is really quite frustrating because just because people people have disabilities does not mean, I want to repeat that, does not mean that we're incompetent.
Good point. And what about you, Patty? I know you had shared some things around this as well.
Yes, doctors have a hard time to understand me. They don't give me a picture board to help communicate. I use my phone. I have an app that I made with pictures on it. And some healthcare, I open and use my app. Some don't. Most of the doctors don't have time.
Okay. Yeah, I do remember, Patty, as we prepared for today's webinar, that was an issue that kept coming up again and again, is that issue around time, and making sure that there is enough time to even have the support you need to be able to communicate and really understand your doctor, and for your doctor to understand you. So let's move on to the next slide. How does bias influence how you are treated by healthcare professionals? So let's look at some of these kind of key areas around lack of respect, devaluation, and discrimination. And Keisha, I think you're going to talk about those first 3 bullets. Do you want to give us more of your kind of your insight into that?
Yes, of course. Lack of respect is foundational to everything we're talking about, which basically means that we need and want healthcare providers to treat people with disabilities like human beings. As human beings, we all are, and the lack of respect is actually a form of ableism, devaluation. People with disabilities are not often believed. Even if we are believed, nothing happens. Healthcare providers do not take action on what we tell them. More about quite often is about 90% of the time. Discrimination. Healthcare providers may say we are filled up when someone with a disability asks for an appointment. See the New York Times article about discrimination.
Thank you, Keisha. Thank you for that overview of 3 key areas. And now, Patty, do you want to talk about the last 2?
Focus on paying attention to my trauma. More trained nurses and social workers to help us communicate and focus on my disability, not the trauma experience. So people just don't, they always focus on disability because they think that we don't know anything, but they should focus on trauma instead. Everybody has traumas in their lifetime.
Yeah, and Patty, speaking of that, I mean, I know that we had talked about that you feel like you personally experienced that happening to you, where someone focused on your, on your disability and not your trauma. Can you just talk about how that experience was for you, or how that made you feel?
That feels like when that if somebody treat you like a child instead of
Yeah.
adult, they think they have to talk to somebody and what to do about trauma. And so if the doctor asks me if medication, or I ask them, explain in trauma, but they don't know what it is.
Yeah. So, we've heard that from different people with disabilities who've been victimized, as we've supported a number of victims with intellectual developmental disabilities over the years who've come to us looking for support. And we've heard this before as well, this issue of if someone has a disability, that becomes the focus rather than digging deeper and asking about trauma and seeing how is trauma affecting that individual. And yet we know that so many people with disabilities are affected by trauma. We know the data shows just how often people with intellectual disabilities specifically are sexually assaulted at 7 times the rate compared to people without disabilities. So this is a big issue. If you imagine going into your doctor's office and no one's asking you about trauma or seeing if you need support around that. So that really kind of brings to light why it's incredibly important that we find different ways to get these messages to healthcare providers. So let's move on to the next slide. So now we're moving to some key takeaways from this section of our presentation today. And what I'd like for Keisha, for you to start with is tell us, what do you think is needed from healthcare providers?
Well, one of the big things that I think is needed is we need healthcare providers to have an open attitude for people with disabilities, and also a willingness to learn, because when they have a willingness to learn about all kind of people and all kind of situations that may be bringing the person with disability into their medical practice, then it's very, very important for them to do that, because when they have a willingness to learn, then they have the ability to see the person with disability as a human being. They healthcare providers, is also important for them to be patient, listen to the patient. And so people with disabilities have all different ways of communicating. Like some of my friends, they are ACC or intuitive communication users. Like for example, they have a little machine that talks with them, talks for them. But just because a person is using a machine to communicate does not mean that the healthcare provider should be de-evaluating them and not listen to the patient. A other important thing is understanding the importance of accessibility. Like, I have quite a few friends that use wheelchairs for their mobility, and I know from the healthcare provider perspective, weighing a person in a wheelchair is difficult, but they people with disabilities should not be saying to them, look, you should go to the supermarket, or or as we had previously stated, the cow wing people, or a weight or a grain elevator. Other importance of accessibility is communication, like have picture charts available, and also have the accessibility of having people in your medical practice, like get an ADA, Americans with Disabilities Act review of your medical practice to make sure it's accessible. Thank you.
Really good points, Keisha, and I'm so glad you added the ADA. We do quite a bit of training around Title II of the ADA, state and local government services, through our National Center, and ensuring that things are accessible, and there are resources out there for those who want to have a checklist of how to tell if your practice is accessible, different places in the community, anyone who provides services in the community, state and local services are required by law to ensure accessibility. So thank you for raising that, Keisha. Now, Patty, what about you? Let's hear from you about what you think is needed.
Needed is learn about the disability 101. In different kind of disability, we got a lot of different kind of people that disability. So you get many of autism, developmental, intellectual. So you need to learn about all different kinds because you don't. People are just gonna say they want to see you. You have to get to know them too, and need to learn. So the other one is to provide enough time for people because sometimes they have to process in the information. So when they don't get the information that like me, my daughter have to write things down for me because I can't get the information right away. And when I get home, it's in my brain now. So and you look about trauma informed youth, trauma informed for the survivors or any people with disability because you should be patient and be more kind and caring. Not like, you don't treat like kids, but it's more, they see you kind and they see you're showing you kindness. And then you get trained that including people with disability and survivors as a part of the team. I always work with the team on my area.
Thank you, Patty. I love that part, that last part especially, of making sure that people with disabilities are part of any training team. And I guess that you're talking about healthcare, but really anyone that you're providing training to, right? About people with disabilities.
Yes.
I wanted to mention one thing that you said around Learning Disability 101. So providing that kind of foundational information about disability. We had recently been working with the National Adult Protective Services Administration to provide webinars around these same kind of topics. And we did a survey with those agencies, and we asked them what was the number one thing that they wanted to know more about, because we're trying to figure out how do we bring more information to APS as well. And the top one that they said was Disability 101. So we do see that there is interest in certain fields around this. So I think now we got to figure out a way to do it that's really meaningful, providing information and training to the healthcare profession group that is meaningful, that's honest, and in a time frame where they have the ability to have the time to hear all of this information as well. But Patty, I did want to just follow up with you on the one about providing enough time. I think you may have mentioned that currently when the doctor that you see has been able to provide enough time for you in your appointments. Is that right?
Yes. Because one thing I train my daughters with my disability. First, I have speech problems. Sometimes I want to pick up certain sounds or certain words. So she will take time, be sure she tells me plain language, I call it, means easy words, explain what she's doing, explain the procedure. So she takes an hour.
Okay.
So
that's a great example of what happens when things go well and things go right. But it sounds like you said you were training her on that. It sounds like she was willing to learn. So that's good, right?
Yes.
All right. Well, thank you so much for providing those key takeaways. And I think that segues pretty well into looking at the next few minutes. We'll be talking about solutions from you. So one of the biggest things, as we all know who have been in this field for any amount of time, is that attitude, the attitudinal barriers, the bias that people may have that they don't even know that they have. You know, we all do have bias in different ways. And the important thing is that we learn to accept that. And then we start realizing, how is that affecting how we interact with other people? How does that affect how I do my job, either in healthcare or as a disability advocate, as a person with a disability? We all have biases. But in healthcare, we really want to be able to address this with kind of key messages that we can collectively share to the healthcare profession group. And Patty, I'll start with you as we think about what are some key messages that you'd like to share with healthcare providers. And we can go to the next slide. Sorry about that.
So it is respect people with disabilities as equals. Listen, believe, and act. Provide training by people with disability. Allow one-to-one interaction. Know why nothing about us without us. It is important to value.
And Patty, I was wondering just about the respect issue that is so important in health, and as a person feeling like you can be heard. I'm wondering, you know, you gave the example of the doctor providing more the time that you need, right? That helps you feel respected.
Yes.
Is there one other example you can give where you felt like your doctor was respecting you?
Well, one thing the doctor respect me because that they really, I respect them. First, they always make sure you respect them. Then they'll give you the respect. That's how I work.
Got it.
Yeah.
So it's a two-way street.
Yes.
But that can be, I guess it can be difficult when you're needing something, and I guess it's about saying it in a way that's in a respectful tone, or if someone's not providing.
In respected tones, be patient. If I ask a question, they have to respect me how I say it. And they answer the medical term and say, can you please say it simple? If they can't, they draw a picture for me, and then they respect me to do what I need. Really.
Got it. Thank you. That's a great kind of practical example. And then Keisha, what do you think in terms of attitudinal barriers?
Well, one thing is that one thing that is rather important is communication, because when people with disabilities go to healthcare providers, a lot of times the healthcare provider doesn't know really how to communicate with the person with the disability that is in their medical office. And so, like I was saying before, communication is so important. Like sitting down on eye level to the person with disability and making eye contact with them, having a gentle tone, like a doctor did with Keisha in the Keisha Goes to the Doctor video that I just described. A other thing is that always use everyday language with the person so that they can understand what's going on. And I in terms of gender disability, in cultural sensitivity, language in images and pictures and icons. It's important for the healthcare provider to understand and possibly communicate with the person about their gender identity. Like if their pronouns are they them, accept it and just say yes. Their their gender identity is like non-binary, not he him, but they them. Also having disability in cultural sensitive language, like if a person comes in from a other country or has been living here for a while, but they're like in the Spanish community, in the Spanish in the Latinx community, they see doctors as and other healthcare providers as the quote authority figure, and they have a very hard time communicating and not in like getting a second opinion. A lot of Latinx community members see that they can't get a second opinion for a medical option because they feel that the healthcare provider is the authority in their culture. They don't go get somebody like that. Also having images and icons like picture charts, which are very important. Also focusing on the abilities and strengths of somebody, not their disabilities, because all humans have abilities and strengths, and it's not all about their disabilities. Also, I want to address invisible disabilities because because a lot of people have invisible disabilities um, here, and the healthcare providers may not see their disabilities even though that they have them, and people with invisible disabilities also have a hard time communicating with healthcare providers because they may not disclose their disabilities to the healthcare provider. But I just wanted to bring in to highlight people with invisible disabilities in this webinar as well.
That is a great point, Keisha. And it can be more difficult, I think, for people with disabilities that are more harder to see, for those individuals to get the support that they need. And we definitely see that among crime victims with disabilities in the criminal justice system too, that can often happen. And it's when the disability isn't that noticeable and nobody's asking for that support or that help, things can be missed easily. If no one is supporting someone to help them speak out about a sexual assault, for example, well, what happens if that trauma continues in that person's life unaddressed? And this can really cause all kinds of other healthcare issues in that person's life. So bringing up that issue around invisible disabilities is really key, and so glad that you brought that up, Keisha. So we did touch on effective communication, but I wanted you both to speak to that a little bit more because it's so core to everything when we think about going to the doctor or working with healthcare professionals. So Patty, do you want to talk a little bit more about just effective communication?
Yeah, sure. So we encourage survivors to learn coping skills. I use it all the time for me. Help them understand they have choices. Help them understand and use and support decision making. And when I go to the doctors, I make sure people talk slowly, clearly, and use simple words that I can understand. Change the medical terms. Means they use the medical terms, use the simple words. My doctor will spend time with me, time limits. It don't work when a person is feeling trauma
Mm.
and as a disability. Find the right doctor for you for what you need. Thank you.
Thank you, Patty. And I will point people back to that article that was shared, the New York Times article that mentioned the study. That was raised quite a bit around the time limitations. And Patty, I really like that you brought out, it's not just about needing accommodations around disability, but around being traumatized as well. So thinking about both of those things and why more time might be needed. And Keisha, what do you think on this one, on effective communication?
Well, one thing is for communication, I think that we should have accessible formats, including American Sign Language, caption, which I use constantly, icons and pictures, like a icon and picture chart for survivors with disabilities in case they are having a hard time articulating
Yeah.
what they want to say. Just like Keisha goes to the doctor video that I described earlier. The doctor in that case scenario, the doctor told Keisha icons and picture chart so that she could point to where she was hurting. Also, a very important thing is universal design. Universal design facilitates people with differing abilities, differing ages, healthcare systems, office professionals to be patient and user friendly. Like a key example of universal design is when the city of Los Angeles put in several universal design playgrounds for 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 kids with disabilities so that they can play with their non-disabled peers. So everybody can play on this playground using universal design. Universal design environment means professionals and spaces must promote equity for everyone. For example, we use icons to talk about sexual violence projects. When I can't articulate what I want to say, I can always point to the icon.
Great. Thank you, Keisha. And now that we've been able to kind of look at those solutions in both attitudes and effective communication, let's move on to the next slide where we break it down into what can we do about it. So we wanted to look first at individual impact. So imagine that you're talking to your doctor after a sexual assault. What does the doctor need to say when explaining about taking medication? So we're going to use taking medication as an example and ask both of you to respond to this. So Keisha, what do you think on this one?
Example of when I stopped using my medication and I got very sick. After that, I decided to on my own to take it, but I'm using healthcare providers usually to teach back, especially when healthcare healthcare provider is prescribing medications. A good example of a teach back is after the appointment is finished, the main part is finished, the healthcare provider can say to the patient, can you paraphrase back to me what had happened during the appointment? and I would say something like, you told me to take my medication twice a day, like something like eye medication. Then I'll take it two times a day, 4 drops in each eye. And I will say back, I'll say that back to the healthcare provider, and the healthcare provider can correct me if I got something wrong. That's the example of a teach back.
Great. Thank you, Keisha. I think that's a great example. Patty, what do you think on this one?
Well, the doctor explained what happened when you take a medication. They need to tell you about side effects. If you get angry, they would put you in a jacket, even in group home. They should give you the choices. If the meds work, that's fine. If not, then you should have choices.
Yeah, that is such a great example of just helping people with disabilities understand what their choices are around taking medication. And I think this is such an important place where supported decision making is really important. Just like when I mentioned earlier about if you're a sexual assault victim and how do you get support to make decisions around what to do about that. And with medication, it's similar issues. I mean, these are important issues. And again, back to what does it mean to be able to make your own decisions? That you feel valued and respected as a human being. And so we're trying to build that, right? Where that has been lost. The history of people with disabilities not being able to experience that. And so these really practical examples are exactly what we need to hear more of. And what this project will continue to do through our Talk About Sexual Violence project. So let's move on to the, I think we're running a little bit low on time. Yasmina, can you let us know how much time we have left?
We're over. I wanted to have a little bit of time. We actually have only 3 minutes, and we have some pretty nice questions. So I don't know if you want to just sort of conclude, and then we can move into some of these questions. I wanted to make sure that we get into attendee questions and get some
Yeah.
of these.
Well, what I was going to say is where we're at right now actually is moving into the collective impact, and we will be going over some of that. We can move this to our final webinar. So I do think this is a good place to kind of wrap up for now so that we can get to some of those questions.
Perfect. All right. So the first question, one of the first questions was, as a provider just getting ready to start practicing, I'd like to have some picture charts in hand like Keisha and Patty suggested. Is there a good place to look for or purchase these?
This is Keisha. I saw in chat that somebody mentioned Nora Bardaran. And Nora Bardaran is an excellent recommendation from this person in chat, because Nora has a website that says disabilitywithoutaBuse.com, and Nora is a sexual assault psychologist that works with people with disabilities and sexual assault. And so I would recommend clicking on her email in the chat and contact her for that. She's a very good resource for finding out what to purchase charts and stuff like that.
Until the boy maker, that's a good resource.
Which resource, Patty? Can you say that again?
Boy maker.
We'll Board Maker. Thank you. Yes, Board Maker. And if we do have a website for that, we'll get that in there. Thank you. And I did add one too in the chats. Keisha already mentioned that the Talk About Sexual Violence project that she and I work on together, we created a specific picture chart just for sexual assault issues as well. So that is also in the chat. Great question.
Thank you. The next question, it has to do with the bias in training new staff coming into agency. This person stresses the importance of assuming competence and giving assistance when needed, but they noticed a lot of staff just doing things for the person they're supporting. If anyone has tips on training in this area, they would love to hear from you.
So Keisha or Patty, do y'all have any ideas of how, like any training specifically that address that issue? That's a really tough one. It kind of reminds me of in the criminal justice world, where I do a lot of our work from the center's perspective, that officers think that they're doing someone a favor when they're actually just treating them maybe like younger than their age and things like that. And so what we do is we try to come in and not just train on the kind of basic, here's what disability is, and here's how you identify disability, but we really try to help them understand how that makes a person feel when you treat them a certain way. So that really kind of helping them understand how that makes individuals with disabilities feel when they may have never even thought about it at that deep of a level. So are there any trainings like that, Keisha or Patty, that you can think of that you'd like to share?
I think they could go to their local resources.
So any local resources, that's actually a good idea too, with the chapters of the ARC. So we have 600 chapters throughout the country. So connecting with the local chapter of the ARC to see if they're doing any education with healthcare providers in their community. We do have some pretty exciting projects going on out there around educating healthcare. So feel free to reach out to me directly for more information on that.
And for my part of that question, I train my staff. I train my support staff that when they want to support somebody with a disability like myself, to ask, not assume that you like for example, if one of my friends in a wheelchair is going through a door that doesn't have a push button, I always ask, can I open the door for you? Sometimes they say, no, I'll manage. But it's important to ask before you help.
Great point. Thank you, Keisha.
Thank you. This is Yasmina again. Patty, Keisha, Leanne, thank you so much for this amazing information. We will stick around for a few more minutes. We are at the hour. We have recorded this webinar. Please join us on May 10th. I put it in the chat box for our last webinar in the series, Beyond Silos, Trauma-Informed Care for People with Intellectual and Developmental Disability. And we will be picking up where we left the discussion off today. Thank you, everyone. If you have any questions, feel free to put them in the box. There's a QR code to access additional information and the speakers. And feel free to email any of us with any questions. Have a great rest of the day, and thank you. And thank you all. Looks like no questions. So